responsibility to take care of those patients who we were following for so long, irrespective of corona crisis. But I must tell you two important things. Take care and make sure that you protect yourself properly, and you keep yourself away from the family also, and take proper precautions while managing your patients. I take this opportunity to compliment the state and central government for taking extraordinary effort to try and contain this problem. Because if we see Italy and USA, they are going the way they are going. I dread if we go that way, then it's going to be a serious issue. I thank Torrent people to initiate this academic activity, wherein today we are going to discuss our topic, which is sounds a theoretical topic like diabetic gastroparesis. But considering the epidemiology of and prevalence of diabetes in society, I must say that it's a very, very common problem. I mean, in our problem, every fifth person in the society is a diabetic patient, and particularly in type 2 diabetes, where as the age of diabetes will increase, the complications will start arising out of diabetes, right? For type 1 diabetes, it's not the age, it can start coming up earlier also. So if you look at the global data, then 463 million adults are suffering from diabetes, and this number are going to increase up to 700 million by 2045. It takes away tremendous effort at the end of governments to spend a lot of money and manpower to maintain these patients. So the subject for the day is the diabetic gastroparesis. How does diabetes affect our stomach, and what are the symptoms, and what best we can do for these patients, and how best we can treat these patients. Of course, the basic principle of medicine applies here, which is prevention is better than cure, which means that you have to have an extremely good control of diabetes to make sure that the complications doesn't arise. So as we all know, and the people who are watching this PowerPoint presentation with me, they will appreciate that diabetes can practically affect each and every organ of our body. Retinopathy, it can affect retinopathy. Then for eyes, then you have kidney nephropathy, neuropathy, brain strokes, heart, MI, peripheral vascular disease, etc. But our concern today and the point of discussion is diabetes, effect of diabetes on the stomach. So this particular slide is demonstrating that the poorer the control, the more will be the symptoms. If you see, if the glycosylated hemoglobin levels will increase, the progression to retinopathy, albuminuria, neuropathy, and microbiome will keep on increasing. So, nutshell to say that we need to control our diabetes very strictly and try to keep your HbA1c for those diabetic patients. Your patients keep their diabetes at HbA1c between 6 to 7, where there is no significant increase in end organ involvement. So clinical manifestations, of course, as we showed in the last slide, it can practically affect each and every organ of our body. But today we are more concerned about the GI, and the point of discussion today is how does diabetes affect the GIT? See, it can cause esophageal dysmotility, it can cause gastroparesis, it can cause diabetic enteropathy, which can affect the motility of the small bowel as well as large bowel. These patients can present with diabetic diarrhea or diabetes-related autonomic neuropathy, causing fecal incontinence and severe constipation. So if you see the data, the glucose, more will be the glucose, more will be the effect of the glucose on the GI tract. This was appreciated way back in 1958. They labeled this term as gastroparesis diabeticorum. Now, how do you define this? There is not a complete consensus on this issue, but if you've done an upper GI endoscopy or a radiological investigation to ensure that there is no mechanical obstruction from stomach towards the duodenum, still if you find food 4 hours after having your meal, or patient has symptoms which are consistent with gastroparesis, you can label these patients as diabetic gastroparesis. Of course, down the line, we will have a few very important investigations which we need to use in such a situation where the patient has suspected gastroparesis. Now, if you see epidemiology, 1/3 of patients with gastroparesis will have diabetes. Now, for irrespective of any reason, may it be drugs, may it be thyroid, or for any maybe a post-frontal patient with vagal nerve injury who's suffering from gastroparesis. But if you see the epidemiology and prevalence of the disorder, then at least 1/3 of these patients have diabetes. Large single center study showed that 146 gastroparesis patients, of them 29% of these patients had diabetes. To put it the other way around, 75% patients with diabetes have some form of GI symptoms and approximately 18% will have upper GI symptoms. Diabetic gastroparesis can affect up to 25 to 50% of the patients, especially in type 1 diabetes. And in type 2, more the duration of the disease, particularly they say that the cutoff is 10 years, more the duration of diabetes, more will be the effect on the gastroparesis for the prolonged diabetes. Now, we need to understand the physiology of the stomach. The moment you ingest your food, the food goes into your fundus. The fundus starts relaxing, which is called fundal accommodation. The function of the body and the antrum of the stomach, if you divide stomach into three parts, the upper 1/3 is the fundus, middle is the body, and lower 1/3 is the antrum. The upper 1/3 of the stomach will have fundic accommodation. You start eating, whatever goes in your stomach is accumulated in the fundus of the stomach. You have a hormone which is called ghrelin hormone. This hormone is a satiety hormone. So it tells you when to stop eating, and you know all those obesity surgeons, and when they do a sleeve gastrectomy, they remove the fundus because they presume that the ghrelin is the hormone which is going to affect the fundus and which will not let you have your satiety for a longer duration of time. You eat more, your frequency is more, your volume is more, and you tend to get obese. So that was I am trying to impress upon the function of the fundus. The two functions of the fundus. First function is the gastric accommodation, fundal accommodation, food gets accumulated, and then fundus also works as a pump. Now the body and the antrum of the stomach works as a churning machine. The interstitial cells of Kajal and the vagal nerve come into play here. They cause contractions of the stomach, which causes the churning of the stomach, and the food which you have ingested after mastication becomes semi-solid liquid kind of food material. And then fundus will contract, body and antrum will relax, pylorus will relax, and the pyloric muscle relaxation will allow this food to go into the duodenum. So this is the mechanism of gastric emptying, which we need to understand very carefully. Now what goes wrong? For those patients who have a long duration of diabetes, the fundal accommodation goes wrong. There is a gastric dysrhythmia. The interstitial cell Kajal network is disturbed. Enteric nervous system is not working properly. The churning mechanism of the stomach is not happening. Moment a person eats small meal, the fundic accommodation is lost. He feels bloated and there is a very early satiety. Thereby these patients stop eating and they lose weight. Pyloric relaxation does not happen, and when the pyloric relaxation does not happen, the end result is food stays in your stomach for a longer duration of time. We call it postprandial distension. Now what are the factors which will affect the gastric emptying? Now if you distend duodenum, then this will delay gastric emptying. The stomach distension will increase gastric emptying. Liquid content will increase gastric emptying. Parasympathetic stimulation will increase gastric emptying. Cholecystokinin, secretin, pain, anxiety, stress, sympathetic stimulation, these are few things which will delay the gastric emptying. So now if you go back to the pathogenesis, why is gastroparesis happening? Presuming that stomach is like a balloon, and if you have bloated one balloon once, inflated this balloon once, and the balloon should come back to a normal shape, in gastroparesis the muscular activity of the stomach gets lost because there is inadequate neural stimulation from behind. This leads to relaxation of the stomach and the tone of the stomach gets lost. There is autonomic neuropathy, enteric neuropathy, in which involves excitatory and inhibitory neurons both. The interstitial cells of Kajal network gets disturbed. Sudden fluctuations in the blood sugar predisposes to having this problem more severely. Incretin based medication. So my physician colleagues who are there on this webinar at this point of time are aware about these incretin based medications of diabetes, Victoza, GLP inhibitors, you have acarbose, etc. So these medications will further delay the gastric emptying and increase the symptoms of gastroparesis. Now, this glucose gut incretin islet crosstalk. Now, how does glucose affect gut? We will show you later in one of slide, which is very informative. Incretin is there are two kind of gut hormones which are released from the stomach, which are now GLP and GIP. Islet beta cells will secrete the insulin, and the alpha cell will secrete glucagon. The interplay of glucagon and the insulin will maintain your blood sugar in your body. Now, if there are fluctuations, then gut gets its effect, and therefore a longer duration of hyperglycemia causes delays in gastric emptying. Now, this is the most important diagram. I seek your attention to this. Now, if you see, rate of gastric emptying will increase if there is hyperglycemia. If the excess of cholecystokinin, if there is a GLP stimulation is more, then the gastric emptying will decrease. And the increased gastric emptying, which means the stomach is getting emptied fast, will happen if your blood sugar levels and there is a glycemic level or postprandial glycemia is not there. Moment this food which has been turned and pushed into the duodenum, what happens then? Two kind of hormones are secreted, which are called GLP-1 and GIP. These are the hormones which are responsible for causing the glucose, maintaining the glucose level in the blood, and this glucose level will further help you to maintain the muscular function of the stomach and the bowel. Now, the mechanism involved here is that the patients with gastroparesis often show evidence of autonomic neuropathy. Sympathetic and parasympathetic components gets affected. Hyperglycemia is the most cause which causes vagal dysfunction. Now, there is an oxidative stress because of all this, which causes diabetic gastroparesis, and most common gastric cellular defect in gastroparesis is loss of expression of NO, nitrous oxide synthase, which ultimately causes loss of interstitial cells of Kajal. These are the cells which are there in the body of the stomach, which are causing the stimulation of the stomach. Now, there can be a certain amount of drugs or some procedures which can injure the vagus or stimulate the vagus physiologically. These two things will have the same effect, which the injury, like if you do a fundoplication of the patient for gastroesophageal reflux disease patients, then these patients will develop diabetic gastroparesis. Now, if you while you are managing a patient who comes to you suggesting that this patient has postprandial distension, he has nausea, he has vomiting, or his previous stable GERD, gastroesophageal reflux, has suddenly gone bad, and he has a diabetes which is type 1, then duration is not important. He has a diabetes which is type 2. In that case, you need to take a very strict and very important case, taking drug history of these patients. You have to understand that opioid analgesics, anticholinergic agents, tricyclic antidepressants, calcium channel blockers, progesterone, octreotide, interferon alpha, L-dopa, fiber, sucralfate, PPIs, all these medicines are responsible for causing delay in your gastric emptying. And the medicines which are good for improving the gastric emptying, metoclopramide, erythromycin, will come to it later on, beta-adrenergic receptor antagonist, legosteroid, domperidone, cisapride, and few of these medicines we know now are not available in society anymore. Now, what are the common clinical manifestations of this problem? These patients develop nausea, vomiting, they have constipation, they have diabetic diarrhea or incontinence. Now, when we talk about incontinence, there is a very important thing. When there is a gut dysmotility, then the fecal matter in the colon gets desiccated, and these patients sometimes have pseudo-diarrhea. So the simple answer to their problem is just clear the bowel and change their lifestyle pattern, they will improve. They can have a diabetic diarrhea, that is autonomic neuropathy, and the sphincteric function gets lost, gas is bloating, early satiety, abdominal pain, stable GERD gets increased in severity, the poor appetite and weight loss is there, feeling full quickly when having meals, and when they check their blood sugar is not good. Now, this is important. See, when you have to do a disease, when you have to address a disease entity called gastroparesis, then you have to have a definition. So this definition has to be a definition which can be used by all the researching people to document their results so that there is subjectivity to their results. So the scoring system was devised, which is called gastroparesis Cardinal Symptom Index. So which includes nausea, vomiting, abdominal bloating and early satiety. Now evaluation of the patients with gastroparesis is based on the GCSI. Now GCSI scoring was developed to assess the core symptoms of gastroparesis. It takes into account vomiting, inability to finish a meal, excessive bloating, excessive fullness, stomach fullness, retching, loss of appetite and abdominal distension. The GCSI score is labeled from 0 to 5. Now if you have a score of 5, which means that you have a bad gastroparesis, and lesser the score, your gastroparesis is less severe. Now what can be major complications of diabetic gastroparesis? Esophagitis. These patients tend to vomit, they have severe nausea, they can cause Mallory syndromes, malnutrition, there is nutritional depletion, volume depletion, they can become acute, can precipitate acute renal failure in these patients, electrolyte disturbances can happen, reservoir formation, and they can develop hyperglycemic emergencies. Now if you see, we've discussed about what gastroparesis is, and now you have a patient who has all these symptoms of nausea, vomiting and a stable GERD which has gone bad. He vomits, he has severe nausea, he is bloating, he is losing weight and all these things. Then we presume that patient has gastroparesis because his history of diabetes is more than 10 years. Now we reason to suspect that he has gastroparesis. Now what next? So there are certain investigations which are of tremendous use and which can help us to diagnose the problem, and once we establish the diagnosis, then comes the specific treatment related issues. So scintigraphy as of date is supposed to be a gold standard investigation for diabetic gastroparesis. It is a physiological test, it is a non-invasive test, and it is quantitatively measures gastric emptying, and it is sensitive to the measurement of emptying of solid due to the fact that liquid emptying becomes faster. So this is a picture where on the left side you have a normal gastric emptying, on the right side there is a delayed gastric emptying. At 2 hours you see the intensity of the technetium is there in the fundus area only, whereas in a normal person it has gone up to the duodenum. At 4 hours, most of the tracer is still in the stomach, which proves that this patient has diabetic gastroparesis. Now, this is a complicated investigation which requires a radioisotope lab. Quite possible that radioisotope lab may not be available at each and every place. So you can simply ask your ultrasonologist to go through how sonography can help you to assess whether the patient has gastroparesis or not. Now what we need to do in this situation is that you do an erect ultrasound after patient has taken adequate meal, and you repeat this ultrasound after some time, and this is how the picture looks like. If you see, there is relaxed and the capacious stomach, and after around 2 hours, if the stomach gets contracted like this, then we presume that patient has adequate gastric emptying. If not, then probably the patient has gastroparesis. Then MRI is another investigation which can be of use to us, and gadolinium induced MRI can be done. And this is one picture wherein you see patient was put on azithromycin because he was symptomatic gastroparesis, and we have documented that there is a niche which has started coming up after starting erythromycin for 4 to 6 weeks, which means that erythromycin works very well into this situation if required. Now PET CT scan can also be done. These are investigations which are rarely utilized, but in our general practice, my suggestion is, let's read GCSI properly. Let's remember the symptoms, which are major symptoms of gastroparesis. Let's take a good drug history, what all drugs patient is taking, and review the whole situation in toto. And then the simple way of assessing whether this patient has gastroparesis or not, if the upper GI endoscopy is available, you can do upper GI endoscopy after 4 hours. Make sure that there is no mechanical obstruction, and if you have access to the radioisotope lab, then scintigraphy can be done, or else then you can train your radiologist to do standing ultrasound to assess the gastric volumes. Now, there are certain investigations which are not very commonly available. One is called a wireless motility capsule. So this wireless motility capsule is expensive equipment. I am not aware whether we have this particular capsule available in our country or not, but I have gone through the literature of this capsule, which says that it's an expensive equipment of $15,000 US, which gives you a picture like this, which shows you the pressures in the stomach after meals, the pH in the stomach and the temperature in the stomach. All these things put together, we can assess whether this patient has gastroparesis, yes or no. Now, how do you manage these patients? The dietary modification is important, lifestyle interventions are important, prokinetic agents, we'll discuss something about it, antiemetic medicines, we'll talk about it later, and the bottom line, prevention is better than cure. Do not let the gastroparesis happen. Keep educating your diabetic patients to take a good control of diabetes. So, the dietary modification here would mean that fat and fiber content should be reduced, carbonated drinks should be avoided, multiple small low-fat frequent meals should be taken. Instead of taking a heavy meal in the morning and heavy meal in the evening, a person should take multiple small frequent meals which should have low content of fat in it. Patients and family education improves awareness. He understands his symptoms better and he reconciles the fact that he needs to take good care of his sugar status in the body. Now, glycemic management is very important. We should request and we should ask this patient to be meticulous in managing his blood sugar and try to keep blood sugar below 180 milligrams per deciliter. Then consideration of continuous subcutaneous insulin infusion for controlling sugar because in diabetic gastroparesis, there's another important thing. Sudden fluctuations into your blood sugar levels will precipitate your symptoms of diabetic gastroparesis. A stable gastroparesis, a GCSI index of 1 or 2, if there are sudden fluctuations in sugar, then the GCSI index will increase. So now this slide is quite important for those patients of type 2 diabetes who have developed the gastroparesis and you have diagnosed that this patient has gastroparesis. So therefore oral agents have no role. We need to switch these patients to insulin because the pharmacokinetics will get disturbed. They can get hypoglycemic episodes. Biguanides do develop GI intolerance. Sulfonylureas have significant risk of hypoglycemia. Acarbose inhibitors may be beneficial, but they have other problems of causing diarrhea and abdominal distension. So insulin is the answer for the kind of a problem. Patient, we know type 1 diabetes, there are no questions asked, they need insulin therapy. Long-acting insulin, intermediate insulin, howsoever, the glycemic control has to be done meticulously well. Now, the American College of GI and American Gastroenterology Association has recommended few guidelines about use of prokinetics. Now we're coming to the management part of the diabetic gastroparesis. Their ability to intervene or arrest this vicious cycle, thereby improving glycemic control. Now the important thing is, your gastroparesis will, if you improve your gastroparesis, your glycemic control will also improve on its own, and if you improve your glycemic control, your gastroparesis symptoms will also improve. The GCSI will improve, and the score of GCSI from 5 will come down to 4 or 3 if your glycemic control improves. So the majority of the prokinetics which have been studied for gastroparesis is metoclopramide is one and domperidone is another one. There are certain more medicines which are also of use, and particularly etopride. This is a kind of a medicine which can be utilized which has side effects not there with domperidone or metoclopramide. Now if you see this chart, the most well-studied medicine is metoclopramide and another well-studied medicine is domperidone. The metoclopramide has been studied in form of tablet, nasal spray, injections and everything. Nasal spray phase 3 trial particularly effective in reducing nausea and upper abdominal pain in patients of gastroparesis. There is a new medicine which has come, which is called Rilamorelin. So this Rilamorelin means that this is a ghrelin hormone analog. It increases the gastric emptying and significantly reduces the core symptoms of gastroparesis. Then you have domperidone. Domperidone is a wonderful medicine. We all have been using this medicine liberally, rather I would say. Maybe sometimes we are overusing it. But once if you have diagnosed that patient is gastroparesis, domperidone is a medicine of the choice. It improves symptoms, reducing overall gastroparesis symptoms of severity and early satiety. PPD, which is postprandial fullness, goes down, nausea goes down as well. Now etopride is another medicine which is a newer medicine. The available data is less about etopride as compared to metoclopramide and domperidone, but we know the side effects associated with domperidone, particularly because of domperidone antagonizes DOM-D2 receptors and inactivates the acetylcholine esterase. This is how the etopride acts, but the side effects of the domperidone and metoclopramide are not there with etopride. There is a longer duration of action, so which can be a reasonably good alternative instead of domperidone for those patients who are intolerant to domperidone or who develop side effects because of domperidone. We can switch them over to etopride. Now, unique features and safety of etopride in comparison to other, we know that it does not prolong QTC interval. The wonderful drug tegaseroid and cisapride were available, which were very effective, but unfortunately because of their effect on QTC prolongation, there were incidences of sudden cardiac death. Therefore, those medicines were discontinued. The same disadvantage is not there with etopride. It improves your gastric emptying. It also has its effect on esophageal peristalsis. Therefore, no major side effects with etopride. Etopride is another molecule which can be of use to us. Now, there are certain anti-emetic medicines which can also be used in diabetic gastroparesis, which is phenothiazine is one of them. I must say that phenothiazine is a good medicine to be used as a bailout medicine sometimes, but usually we use it lesser. But this is prochlorperazine is a good medicine to use because it improves your gastroparesis symptom. The serotonin receptor antagonist includes ondansetron, granisetron, and dolasetron. These medicines can also be utilized in diabetic gastroparesis patients. Now, presuming that in spite of optimum medicine, the patients are not responding and the quality of life is getting disturbed, the glycemic control is not being managed properly because whatever patient eats is there in the stomach for a longer duration of time, there are certain alternative medicines which can also be used. Intrapyloric botulinum injection. The situation is analogous with achalasia cardia, where in achalasia cardia also we know that the muscles in the lower end of esophagus the circular muscles are very tight. They don't permit your food to go into the stomach. We use botulinum there also. Same was used here, and convincing results were found in idiopathic and diabetic gastroparesis both. So presuming that the patients are not responding to the medications and lifestyle modification, then this is an alternative therapy for them, because botulinum toxin is a potent inhibitor of neuromuscular transmission, and this has been reported to improve emptying, and the effect of single injection of botulinum will stay there for several months and patient will stay comfortable. Other therapies is a transpyloric stenting, which may be useful as a salvage therapy. Symptomatic improvement, it gives rapid gastric emptying, complications, stent migration may occur. Usually placement of these stents, this is a palliative measure. Normally we do it for malignancy patients, and we wherever you have inadequate life expectancy, there only the foreign body like a stent is placed. But in an extreme situation, you are against the wall, these are some therapies which are suggested. Now, gastric electric stimulation, FDA has approved this therapy, wherein you have a stimulator which is kept on your anterior abdominal wall, and when you stimulate the stomach body, then the gastric emptying improves. There are certain other therapies which are now in process of consideration. One third space endoscopy procedure, which is called a GPOM, gastric peroral endoscopic myotomy, wherein what you do, you start from the body of the stomach, you create a tunnel between the mucosa and the muscle, and this tunnel goes across the pylorus into the first part of duodenum, and then you open up the muscle and you relax the pylorus and then come back and you close the entry point, which is called GPOM, which is also being used. So far, the number of cases of GPOM done for classical patient of gastroparesis is not there. So this kind of a therapy is still under study. Now surgical options can be, vertical sleeve gastrectomies can be done. Then you can do gastrojejunostomies for these patients. Now, this is another way of managing these patients in a desperate situation. Gastrojejunostomies can be done. This is a way and method and technique how percutaneous endoscopic gastrostomy or percutaneous endoscopic jejunostomy is done. Now, to conclude the topic, how do you finally manage diabetic gastroparesis? The most important thing is that glycemic control has to be good, which will require a lifestyle modification and pharmacological therapy. Pharmacological therapy in an established patient of GCSI diabetic gastroparesis of more than 3 should be switched over to insulin. Now, evaluation of the drug therapy, as I discussed in the beginning, while you are taking history of these patients, make sure what kind of drugs patient is taking. Try to discontinue and remove from his prescription the drugs which he is taking, which are indirectly responsible for increasing the decreasing the gastric emptying. Then assessment of the other comorbidities, and the other comorbidities should be addressed as well, and symptomatic relief can be given by pharmacological therapy by using prokinetic medicines. So identify the cause, diagnose the problem properly, exclude all other differential diagnosis possible, then lifestyle modification, pharmacological therapy, and finally, if you're against the wall, surgical treatment. So this is in nutshell about diabetic gastroparesis. Now, if the people who are attending this webinar, if they have any questions, I'll be pleased to answer. So the carry-home message for the webinar is, diabetic gastroparesis is a challenging problem. The important thing is, it is there in society, it is there in patients who are coming to you regularly for your OPDs, but you are not able to identify the problem. But if you keep our ear and eyes open, you'll find that reasonable number of patients with gastroparesis will be there in your OPD. If you address this problem aggressively, the quality of life for these patients will improve. A gastric emptying study should be performed. Medical therapy should be initiated. Antiemetic therapy is the foundation for gaining initial symptomatic control for these patients. Surgery is last resort for these patients. Diabetic gastroparesis is a complex disease requiring multifaceted approach. So thank you so much for patient listening, and if there are any questions, I'll be pleased to answer. So there are certain questions which have come here. Dr. Vijayvargi from Bhilwara has asked a question: what is safest drug used in APD in corona patient admitted in ICU? Sir, unfortunately, corona is one disease which has not been studied so thoroughly. So therefore, the scientific support for suggesting a particular medicine is not there. But yes, most of the PPIs which we are using today are safe PPIs, and we can use them as and when needed. So Dr. Verma from Pilani, he's asked role of levosulfide as a prokinetic agent in diabetic gastroparesis. A wonderful question, Dr. Verma. Levosulfide is another medicine which can be used. It's the same group of medicine as metoclopramide, with more or less the same kind of mechanism of action. We can use levosulfide also, but with levosulfide, there are certain problems, and levosulfide causes a Rabbit syndrome. So those patients who have movement disorders, this is a drug which is not there. Personally, levosulfide in females causes galactorrhea, prolactin kind of symptoms which come up very fast with levosulfide. And for those elderly patient, levosulfide should be avoided because the prevalence and incidence of rabbit syndrome is very high, and we must appreciate that if you have seen rabbit syndrome once, it is an irreversible situation if timely levosulfide was not withdrawn. Therefore, the primary medicine will be domperidone, but yes, of course, for a younger population, levosulfide can still be used. Now, Dr. Verma has another question: presenting feature in presence of neuropathy. See, the autonomic neuropathy appears after 10 years of the disease, and when you diagnose autonomic neuropathy, usually these patients already have gastroparesis in place. Dr. Vyas, he said hello to me from Milada, Jodhpur. Hi, Dr. Vyas, how are you? Compliments, stay safe and stay at house. And when you're taking care of your patients, be careful. Try and accumulate as many masks and PPE as possible, because this is a situation where we need to be we are asked to do our job, and we will, and in the service of the society and the country. But at the same time, we need to take care of ourselves as well. Now, Ankur Mittal said it was good. Thank you, Ankur. Then Dr. Verma has another good question: ecostiamide in diabetic gastroparesis. Now, this Dr. Verma has a lot of questions and very informative questions he's asking. Ecostiamide is a good medicine to be used, but unfortunately, the effect of ecostiamide will appear after at least 12 weeks of therapy given, and then you have to use it for a longer duration of time. It's a tedious dose medicine, it's an expensive medicine. So when you can get your job done with domperidone, yes, if some patient has, reasons not to use those medicines, ecostiamide can of course be used as well. Dr. Sandeep Sharma, he is a very prominent physician of our city, Jaipur. What should we advise these patients to eat who have diabetes mellitus and gastroparesis? Yeah, avoid fat, fiber, and obviously we have to avoid sugar. Wonderful question. See, Sandeep, there are three important things. The most important thing is you have to ensure that patient has gastroparesis. Now, if you have gastroparesis, then you have to avoid fibers. Because you see, if you have given them more fibers, then their gastric emptying will get delayed further. Unless if GCSI score is up to 2, restrictions on fat and fiber is not there. This is particularly meant for those patients whose GCSI is 4 and beyond. Now, Sandeep has another good question: is there any correlation between peripheral neuropathy and development of autonomic neuropathy? This is again a good question, Sandeep. You know better than me in this particular situation that by the time patient develops autonomic neuropathy in type 2 diabetes mellitus, it will happen after 10 years. In type 1, there is no such kind of a restriction. But by the time patient develops symptoms of autonomic neuropathy, and if you document patient has significant postural hypotension, most of the other effects on other organs of the target organs of the body have already happened. Dr. Kamal Kapoor has asked me a question, nicely covered. Thank you, Kamal. Thanks for sparing time. Jayashri, patient with well-controlled pre-diabetic type 2 Guillain-Barré syndrome and suffering severe constipation, what drugs to be used and what not? Well-controlled diabetes to developed Guillain, your patient had developed GBS, right? See, GBS is a demyelinating disorder. So GBS is a disease which is not a central disease, a peripheral disease. So the most of our prokinetic medicines are centrally acting. They would probably not affect a GBS patient, so I presume, but better to take opinion from a neurologist as well. For these patients who are bedridden patients of GBS syndrome, who have a severe constipation, my personal choice for this kind of situation will be using polyethylene glycol for these patients on an intermittent basis and increasing fibrous content and doing aggressive physiotherapy, and yes, increasing liquid content in their diet as well. And for these bedridden patients of GBS, if they develop fecolith infections, then my plan and policy is to do a bowel wash maybe on a fortnight basis and give them good fiber and good water intake. Those symptoms will go down. So Dr. Kamal from Bara has a question: best prokinetic to use for gastroparesis. See, there are certain things Dr. Kamal I didn't cover, which was icosapamide I didn't cover, levosulfide I didn't cover, but yes, the largest study and scientific data is with metoclopramide and domperidone. So you can safely use these medicines. If these patients develop any kind of a problem with these medicines, then the second line of medicines can be then like etopride can be used. Then you can use icosapamide, then you can use the levosulfide also with the precautions we have discussed earlier. Sanjeev Garg is also there with us. He's a senior physician and diabetologist of our city. Hello Sanjeev, take care because you must be meeting many patients with the URI and LRI kind of symptoms. So I will suggest that stay careful and stay alert. How long prokinetics can be used in diabetic gastroparesis? Unfortunately, to say that you have to use them indefinitely. Over a period of time, you keep evaluating these patients and you can play around with the dose of prokinetics for these patients. Kamal has another question. Use of haloperidol in this disease, to my knowledge, it's not there. Thank you. So, if there are any more questions, I'll be happy to answer, or let's conclude. And before we conclude, I will probably reinforce the point that let's be very, very careful about this crisis. Let's stay at home and let us use the telemedicine, WhatsApp communication, Zoom, etc. to stay in touch with our patients and help them as much as possible. The Rajasthan Medical Council certainly came up with a notification that हो गया कितने बजे
107 पे था ना 640 में।
अच्छा तो उसमें कोई क्वेश्चन नहीं थे। स्ट्रीमिंग विल स्टॉप इफ यू एग्जिट नाउ।
फोन करूँ उनको?
हाँ फोन कर ले, लेकिन मेरे क्वेश्चंस ना उसे बोल कनेक्ट कर ले वापस, क्वेश्चन है तो जवाब दे लेते हैं।
हाँ हाँ वही आंसर देने के लिए पूछ रहे थे कि अभी वापस कनेक्ट करना होगा आपको। कनेक्ट है वो बोल रहे हैं आंसर दे दीजिए।
अच्छा अच्छा ठीक है सर, ठीक है। सॉरी आई थॉट आई वाज नॉट कनेक्टेड and I'm pleased to see Dr. Bhandari is also listening to my talk. He is my mentor and I've learned so many things from Dr. K. M. Bhandari. He's asking us a very good question. What is the incidence of psychosis with these medicines? Sir, levosulfide is a problem which we need to avoid. Most of the other medicines are safe. In females, we have to be careful about the prolactin related side effects of the medicines. Dr. Jain from Jaipur has a question regarding diabetic gastroparesis. He says that the session was interesting and informative. Thank you, sir. Thank you so much. And Dr. Anil Agarwal also says that it was good. So thank you. I think we made good use of our time. So I'm still on air. I mean, if there are any questions, I'll be pleased to answer. So I have gone back and I've seen most of the questions are answered. I think let's conclude the show.